Good morning, everybody, and welcome. I'm Helen Phillips, and this is the first meeting of 2022 of the Chesterfield Royal Hospital Board. Happy New Year to you all, and a big thank you in advance for making the time to be with us today. We have a number of welcomes to offer. This is, I hasten to add, a meeting in public rather than a public meeting. So there isn't an expectation that there is an opportunity to involve people who are attending the meeting to participate. But with Chesterfield, we really try to do our very best to make you feel very welcome. And at the end of the meeting, we do come back to those who have been kind enough to observe it to ask you how you found the meeting and if there's anything in particular you want to comment on or raise. So we hope that you appreciate those gestures within the context of a meeting in public. So the warm welcomes I can see on my screen, and I can't see everybody on my screen, but I understand that we've got a number of our governors joining us. We always appreciate governors coming to observe board. So a stalwart of board attendance, Judith Rees, is on the line. So thank you, Judy, for being with us this morning. Also, Eddie Lewis and Ruth Ludwig, and your regulars, and we really do appreciate you coming in the way you do. But we've also got Nick Wood. I think, Nick, you're on the top of my screen. You may not be on the top of everybody's. If you like to wave, because people won't have seen you before. And Nick is the new governor for North East Derbyshire. So we're particularly impressed that you're off to a good start at the beginning of the new year, Nick, getting your bearings in respect of your new role. So thank you very much for doing that. And the other new governor we've got on the call is Carol Warren. And I can see you on the bottom right of my screen, Carol, but if you give a wave to everybody so that they can put a face to the name. So governors old and new are very welcome. And of course, we've got a board story later today with Liz Claridge and Claire Langford joining us. And then we've got the Freedom to Speak Up report, where we'll be seeing Abby in the way we normally see Abby. But Rebecca is also joining Abby today. So we'll see more of those colleagues when we come to the relevant items. In terms of the conduct of the meeting, I have encouraged, as I always do, my executive colleagues to be brief in their introductions and be very clear about what sort of conversation it is they'd like the board to have and anything particular that they want the board to consider, discuss or debate. So if it seems a brief introduction, that is because we've all been quite diligent and read our papers, not for any other reason. And I think the final thing for me to say by way of introduction is that we have only one apology today, and that is from our medical director, who's having a well-deserved break with his family on the ski slopes. And we very much hope that he managed to get there and that he's enjoying himself, and he will be back with us next week. So that's it by way of preliminaries. And on that note, I'm going to pass across for our first substantive item, which is our board story, to Zoe, please.
Thank you, Helen. I'd like to welcome Liz and Claire to the meeting today. Hopefully you're with us, both of you. They're both leaders in our education team, and they're going to talk about the board story, which is all about the impact of the pandemic on the work that they deliver and how they've sort of changed that, and also how they've done that working with system partners. So I will hand over to you both. Thank you.
Thank you.
Hello.
First, Liz, yeah.
I was just about to say, I'm sorry, we've not worked out who's going first. That's a bit of a rookie error, isn't it? So, hello, I'm Liz Claridge. I'm the staff development and apprenticeship leader, obviously within this trust. And I'm sure a lot of you have met me previously. So what I am actually going to talk about today is a little bit about some system-wide working that we have been doing with some of our partners within the local area and authorities. The staff development and apprenticeship team do a lot of system-wide working, and one of its main work streams is for us to engage with schools and and deliver careers advice and raise awareness of the NHS for a future career for young people. So as part of that, we work alongside the D2N2 group, which is like a cornerstone type group, an employer hub, where we meet quarterly with other local employers, not just NHS employers, but local employers, to try and find out how we can raise careers awareness within schools in order to help the schools meet their GASB benchmarks. So the GASB benchmarks, schools, the government have put like 8 benchmarks to schools to try and increase the amount of careers information that young people are given within schools, and we work together to try and improve their information around careers advice as part of that group. So as part of that group as well, we were asked to engage with a local SEND school and do a pilot around virtual work experience. And we worked in partnership with Speakers for Schools to deliver a virtual work experience programme. So this went over 5 weeks. We had one session every week for 5 weeks, and we delivered that programme by us doing basic life support talk sessions and engaging with the young people to, in an interactive way around basic life support and what to do if somebody was choking and that type of thing. We also did quizzes around the different roles within the NHS and what they understood about them. We did set them some homework, and they drew us some really nice pictures and various things like that and sent them in so that we could then feedback about them on the next session. We did a patient story. So we had a lad called Daniel that broke his leg, and we then went through all the different careers or jobs that they may have incorporated when they came into hospital, went to x-ray, who gave them the meals or that type of thing. And we'd been around and we took various photographs of those individuals in our workplace so that we could, use real life people to demonstrate that. At the end of the 5-week session, the last session ended in a Truss Tour. So we organised a Truss Tour for these young people to come. We made sure that we were safe, that we had got a nice parking area, that we'd got some wheelchairs for the ones that needed to have wheelchairs. And we actually did a Truss Tour, not into clinical areas, but very much to the departments, what we'd already shown as photographs on, as part of the other sessions. So we demonstrated, this is the front of A&E, and we walked round. We also did some sessions around some of the hazard signs, the health and safety hazard signs that you find in all workplaces. We'd done one of the sessions around that. And as we were walking around the trust, one of their objectives was to find as many of those hazard signs as they were walking around as well, just so that it was a little bit more interactive as we walked around. At the end of that session, we went into one of the tents, the big marquees that we've got on the trust, and then we did a presentation of certificates and celebration of success, and we all clapped them and had a photograph taken and things like that. On the whole, it was a massively rewarding experience, and it was really nice that it made us think about what young people with SEND conditions might be able to find careers within the NHS. We didn't just focus on nurses and doctors that probably would have been unobtainable for the young people. We were trying to think about some of the roles that they might be able to do within the hospital, and I guess it sort of gave them a little bit of hope for the future for what they might be able to do. And definitely from our point of view, it raised our awareness of what we might need to do to be able to include them more in our recruitment processes and things like that in the future. So on the whole, it was very, very rewarding thing to do. And we would like to try, and there are such things as supported internships, and in the future we would like to try to increase the number of supported internships that we have available within Chesterfield Royal for young people such as these. That's me done. Claire, do you want to start? Does anybody have any questions about mine before we move on to Claire's? Because hers will be quite a lot different.
Colleagues might well have, Liz, but whilst they're thinking of them, let me say huge congratulations. This is the sort of thing that will be easy not to do at the best of times, let alone easy not to do in the context of COVID. And when we know that, you know, we've got the pandemic and we've got the climate crisis, and sitting in and around all of them is the workforce crisis. You know, it's fabulous to hear about what you've been doing, and also in the context of our aspirations to be an anchor employer in the system. And we can't be an anchor employer unless we're serious about embracing diversity in the workforce. So it's a really, really powerful story you've told us. And you've told it in such a kind of matter-of-fact way, you know, that we could be at risk of taking it for granted. But it's a huge achievement. So very well done you. Anybody like to comment at this point, or would you like us to go straight to Claire first? Let's go to Claire and we'll come back and have the conversation on the round, Liz.
Thank you, Helen. You've actually set me up perfectly with what you've just said, because I'm actually talking about students and our future workforce, so that's really great. My name's Claire Langford. I look after all non-medical students that come to the Trust, so this is anyone that's on a BSc or MSc programme. And I'm going to just talk a little bit about mental health initiative that we've used trying to get mental health students into the Trust. So a little bit of background. At the beginning of the pandemic, the majority of students' placements were cancelled and theory blocks moved to fill the gaps to ensure students would continue to learn and progress on the degree programme. So as we're hitting the 2-year mark in the pandemic, those students whose placements were cancelled are coming to the end of the 2nd year or the 3rd year and have a really large deficit in their placement hours. This, combined with the increased number of the students on the course, the consequence of the A-level teaching assessment. So I imagine you've all got some family members that went through having A-level tests or no tests, or having assessments and all that happened over the last couple of years. Because of that, a lot of the universities allowed students to join the course and actually join that professional programme, which meant that the number of students on the programme vastly increased. And this year, I think he's just said it's about 34% for nurses, 27% for AHP. So that's a lot of students on a course that's requiring placements. So what we had to do at Chesterfield Royal was be really creative of how we could actually offer placements, because as we all know, we've got maximum number of patients in the Trust, and we've also got a lot of staff off sick, but we do have to get those students out there. So we've got some of the areas that we can't use, like clinics, so we had to be creative of how can we get more students into the Trust to help them get those hours to qualify and become our future workforce without impacting on other students and their learning, and also on the care that we provide for patients. So what we did is we looked at the mental health nursing students. Now they have the largest deficit within nationally within nursing, and this is because a lot of their placements are in very specialised areas with one-on-one care, and because of the room restrictions or the community settings, they're not allowed to go into those areas. So what we did as a trust, we looked at the places that we could allocate those students to, because I think we all recognise that patients coming to hospital in adult acute areas don't actually just have physical illnesses, they actually have mental health issues. So over the last sort of 6 months, we've placed 70 plus mental health students within our adult acute areas. We've started with the areas like Ashover and Durrant, which are our elderly acute frailty units, and we've also put them in places like the Old Ridgeway, which is now on Markham, which is a medical gastro, and ED and EMU. And the feedback we've had from those 70 plus students is it's outstanding actually, and we're going to start a project where we're going to look at maybe hopefully employing mental health students in the future into those adult acute areas. Some of the feedback that the students gave us was that they observed the impact of a long stay for their patients, the mental health impact. Now, as I'm an adult acute nurse by background, and that isn't something that we tend to look at. We're looking at the physical aspects, but these students, particularly on Durham ward, focused a lot of their attention on the communication with those patients because they recognised that they were really struggling with the impact of actually being an inpatient, and they deteriorated over the weeks or the period in there. They also picked up delirium 2 days, 2 days, 1 day earlier than most of the adult acute nurses because they could pick up the changes in the conversation. So we're hoping to carry on this experiment with the mental health nurses. We do fit it into the gaps around adult nurses, but the hope is we can get a job description. So we're currently looking at papers and other trusts that have done this, write a job description and run it by the heads of nursing again, and Krishna and Sarah, just to see how it goes and if we can start employing mental health nurses within those adult acute areas, because we've got 3 already that would love to come and work at Chesterfield Royal, which is something they would never have considered because they went in to be a mental health nurse and they were considering community or working within children's and CAMS, and now they'd love to work somewhere like acute frailty, which I think is amazing. And that's it from me, thank you, unless anyone's got any questions.
Thank you very much, Claire. You make it sound like it's amazing and it had nothing to do with you. So clearly you've been a big part in making all of this happen. So you must reflect on that as well as the success of the initiative itself. We've 3 colleagues who'd like to come in, I'm sure probably covering both presentations, but let's start off with Krishna, please.
Thank you, Helen. So a huge thank you to both Liz and Claire for 2 very, very different projects, but will have implications. So first from Liz, inclusivity. I've worked at another organisation where we've actually looked at different roles and actually sort of having that understanding about being inclusive in that wider sense about what we could do to support people coming into our organisation as from an employment point of view. So I think the journey that you've had and the learning, I think, has been tremendous. So I just wondered, sort of, did you, it seems very powerful, and what was the positive for you then, Liz? What do you think? Would you do this again? Is it something that was a one-off, or?
So no, we would do it again. I mean, to be fair, probably we got a lot of different positives out of it than what we first thought that we were going to. It was originally because obviously with COVID, we had to draw back a lot of our face-to-face work experience because we do quite a lot of it within the trust, and we felt that we needed to do something else, and we weren't very confident with the Google Classroom and the virtual work experience. So initially for us it was a bit of a trial so we could get familiar with the equipment more than the underlying thing around the SEND school. But the engagement of the young people was amazing, and probably quite a lot more than if you were to do it with a non-SEND organisation. They really got involved in it, and one of the really nice things, I went to the Cornerstone group the next afterwards, and one of these young people had gone to another organisation to have some equal, some face-to-face work experience. And I was saying how lovely this lad was, and and they were really, really nice. And this other guy from this other organisation says, yeah, he says, I was in the room, and he went, and my coffee went down the wrong way. He says, and I started coughing. He says, and before I could do anything, this guy had come along and hit me on the back because obviously, and I went, we taught him that as part of the basic life support taught session. I mean, we did sort of say, don't go around hitting everybody on the back, if, unless it is a real emergency. But it was really good to see that he'd actually learned something from us, and then he'd gone on and used that still when he thought that somebody was choking. But the engagement was wonderful, and I think the feedback was absolutely fabulous as well. And a lot of the material that we it took quite a lot of putting together the material, but it's stuff we can use for lots of other occasions. Now we've got it, we can actually use it again and again and again. So yes, it was really rewarding from that point of view, and the fact that we actually felt that we were making a difference to these young people. And probably improving their hope for a career in the future, because you know, a lot of these young people don't go into jobs. So the fact that we were giving them some, you know, some options for what they might be able to do in the future, I think was quite rewarding.
That's fabulous. And then just another point, Claire, absolutely, we have employed mental health nurses before, but they haven't stayed, and they haven't stayed because they've not had that richness. So I think what you've done is absolutely incredible, and absolutely, yes, we do need those different skills to be able to impart those skills to support our current workforce. So going forward, absolutely, to have mental health nurses, you know, whether that's on a rotation with mental health or however we do, we can talk outside, but I've discussed it with heads of nursing, they're all for it. So it's a go from us. So thank you.
Thank you very much. Now we've got Sue, Berenice, Atul, Jane and Zoe, all of who'd like to come in, probably in that order. But if you've got questions, I'm going to suggest that Liz and Claire keep them till the end, and then they can come back and address, you know, all and any of the issues you might want to raise. So Sue, please.
Thanks, Helen. And I just wanted, I don't have a question, you'll be pleased to know. I just wanted to say thank you for both of those, and they were really different, but kind of achieved so many of the things that we're all really keen on as a board in terms of, as Krishna said, inclusivity, looking at the digital platform and how we can get things online instead of virtual, reaching out into the community, and also just congratulations to you both for doing that, when it would have been really easy, as Helen said, to just kind of think, oh, you know, this has to wait till next year. But all of the things that go on in the Chesterfield, which are keeping on, doing the right foundational things, even when we're in crisis, are really important. So I just want to say thank you and well done, and sounds like great successes.
Thank you. So, Berenice.
Thanks, Helen. Just to say to Liz, thank you so much for your presentation. The anchor work that goes on within this organisation, and how you reach out to partners, we've shared previously, but just the way that you kind of bring that to life, and you can, even behind the mask, you can see how passionate you are about it. But the important bit for me is, thank you so much, because you've clearly made these people feel comfortable being in this sort of setting. And you know, I still go down to the A&E department and sometimes feel a bit kind of like, oh my God, when you walk in, and to bring, you know, juniors like this into the organisation and give them that memory. Thank you. And I hope this isn't seen as a negative for Claire. I think the work that you're doing is fantastic. I think the area around the frailty and having that mental health support where they can recognise other symptoms, absolutely brilliant. But I always just have this slight worry that we are solving in the acute a lot of community problems, and that it doesn't lead to even longer length of stay, because we end up doing more and more for people. So I just want to kind of make sure that we keep that balance of having that real expert input versus making sure that we still do the right pathway for the patients. But thank you for your work, it's brilliant. Thanks.
Thanks, Berenice. Zoe, please.
Thanks, Helen. Mine was a reflection rather than a question. Thank you, Liz and Claire. That was fab, as I knew it would be. I just reflecting as we talk about sort of ICS development and system working and the governance side of that, and the education team are just really good at naturally working in that way and just getting on and doing that. So Liz and Claire and their teams, and others too. There are other examples, and it's just sort of naturally the way they work with system partners. So sometimes we talk about, you know, examples of working as a system, and I think these are pockets where it was people naturally getting on and doing things without necessarily going, oh, today I'm doing some system working. It's just, you know, part of the way of working to make things as best as they can be.
Lovely reflection, thank you. Atul.
Yes, I add my thanks as well, Liz and Claire. Thank you very much for all the things, great things you're doing. And my question was really around sort of inclusion of minority ethnic communities and people from that kind of background, and what your experience is of you know, interaction or involvement with the minority ethnic communities.
We'll hold on to that one for a moment, Atul, and ask Liz and Claire to comment.
Yeah.
So if I can go to Nora, please.
Thank you. And just to echo what colleagues have said, absolutely fantastic initiatives. Music to my ears, particularly for schools. So important to inspire enthusiasm and open up knowledge about roles within different sectors. And because it's so important, I wondered, do you get access to the schools by invitation? Are head teachers difficult to convince that this should be part of or make space within the systems? Because this is something that I think needs to be run in, much wider across the whole education area, and if there are specific age groups that you target, and also what materials you could pull together from what you're doing at the moment that could be used more widely within some of our career services, because it is a very effective way of ensuring that we're going to avoid skills shortages in the future by inspiring our young people at an earlier age.
Thank you very much, Nora. And last but by no means least, Jane.
Thank you, Helen. So great work, fantastic work, both of you. I won't go over any of the points that might be repeated from what people have said previously, but I'm really interested in the outcomes for patients, particularly around the mental health placements, because I think it's really interesting. We've just spoken about delirium being detected, etc. But I wonder, perhaps a slightly different view to Berenice about the impact on safe discharge and about readmission, because I suspect that we may well make better provision to keep our patients at home and safely discharged and actually cared for in the community once we move them on from the acute, as a result of having different views kind of put into the mix. So I wonder if we might think about that and look at that and think about whether that is actually helping our length of stay, but also our readmission rate as well.
Very interesting points. So I suggest that we take Nora's point about access to schools and broadening that, and the outcomes for patients point and discharge made by Jane on notice, because you'll need time to think about that. But if you're able to comment on Atul's point about ethnic minorities being included now, that will be helpful, or take it on notice if that's better to you. But if there's anything in conclusion you'd like to say, either Liz or Claire, please do so.
I'm happy to say something. We work really closely with the universities to make sure that we do have a good diversity on the programme. So because we look after students before they even start the BSc and MSc and all the way through to 6 months post-qualification, it's very important that we work really closely with the universities, and we are part of the groups at the universities, making sure that there's that diversity, but also as a team we are very aware of how people are treated and how people are viewed. So we make sure we have regular training in line with the university, and we've actually got one next week. I know a lot of the training's been cancelled, but this is an important one that we have to keep, because it's about how we deal, particularly with within Chesterfield. We have quite a lot of African Americans that come on placement here, and they tend to be all based in Sheffield or Derby, and as we all know, Chesterfield is quite a white-led area, so we do have sometimes issues with students and patients and how they communicate with those students. So we're very conscious and aware of that, and we have some training so we can speak to the students and explain how to deal with how they may be spoken to by patients, but also support the students out on placement if that does happen, and then put that support in with the matrons and the staff, because obviously it's quite distressing if a student goes to them and says that they've been spoken to a way that they wouldn't expect, just like it may be for the students. Tends to be the over 90s, they're not expecting somebody maybe that's not white to look after them, so we do work closely with the wards to ensure that.
Thanks for that, Claire. And again, I'm sure the opportunities to increase diversity as we go on will become better as people understand how good an experience they had when they were on placement. Is there anything you want to say by way of a closing remark, Liz?
So from from the diversity aspect, I mean, obviously in Derbyshire we're not terribly diverse, especially with school, you know, the local community. So obviously we do a lot of other system working, and I know as part of Joined Up Careers there is a gentleman at Joined Up Careers who has done some work around care sitting for people from BAME communities, because sometimes people who are from the BAME community want to be cared for by somebody from the BAME community, and I know that Brian has done some work around that specifically, but also part of his role is to engage with different diverse sectors to try and increase the amount of diversity we have within the workforce in Derbyshire anyway, to try and improve people from the BAME communities opportunities, because sometimes they don't feel that is a job for them, so definitely Joined Up Careers are specifically doing some work targeting around that. In terms of engaging with schools, we engage with whoever the school's community is, so we would, you know, obviously we would encourage anything with any of the schools. I think also in Derby, because Derby obviously have a high ethnic community, we have spoke about that previously, about making sure that the schools that have got a high ethnic community are targeted as well, and trying to engage with them, because sometimes those schools aren't necessarily the ones that engage and try and get us to go in. And I know from the South Derbyshire, they're more into, you know, they're looking specifically at engaging with those particular schools that have a higher ethnic minority. So I hope that answers your question.
It does indeed. It does indeed. Thank you very much, Liz and Claire. We start every meeting in public with a staff or a patient story, and it's splendid to be reminded of both the successes and the challenges that we experience as a trust. But of course, we have to take one step back, don't we, to recognise the fact that we've heard one story this morning of maybe 20 or 30 or 40 stories that could have been chosen. And, you know, the fact that we have colleagues of the calibre of Liz and Claire that are embracing these opportunities at the toughest of times is, well, it's quite humbling, to be honest with you. And it's a timely and good reminder of our solemn responsibilities as a board to ensure that we're supporting you in the best way we can. So thank you very much for coming today, and we wish you all the best in continuing to roll out these initiatives in the way you are. So thank you.
So shall I just go back now?
Yeah, just leave it.
Very good. So that brings us on to the next agenda item, which is Angie's Chief Exec report. So all yours, Angie.
Thanks, Helen. And just to update from the time of writing the report, we remain as an NHS in a level 4 incident. And yes, we've had some unprecedented times over the last couple of years now, but the level 4 over January reflects that increasing prevalence of Omicron in our community, which is impacting both on our number of patients in beds and on our staff. And firstly, just want to add my thanks to Liz and Claire, but also to every single member of our staff who continue to go above and beyond to keep our patients safe, and particularly to those who stood up our incident control centre 7 days a week very rapidly over Christmas, New Year, and continue to support everyone to do that. As of today, 85 COVID positive patients in our beds, with 3 in critical care. Workforce absence numbers similar to those that were written in the report last week. Continue the work with our system partners. The 2 biggest issues, I think there's numerous, but those that really are impacting on us are the number of
medically fit patients in our beds who can't be discharged because there's not packages of care or care home staff to look after them, or staff at home to look after them. So daily calls with our system partners and the local resilience forum. Derbyshire continues to be in an incident to work through that. Loads of work happening, just not quite seeing the pace that we need to get those patients home at the moment. And again, I don't know how our staff do it, but everywhere else where that's a problem, and with our absence numbers, we haven't seen the ambulance handover delays and the number of 12-hour trolley waits that other parts of the country have seen. So credit to them. Nothing any of us want for any of our family or friends, but a real increase in delays with ambulance handover. You'll have seen media. And so thank you to our staff that we haven't fortunately had that impact. Again, lots of work around supporting our workforce continues from a health and wellbeing point of view. Military support already in the system and coming in to support us further. Operationally, the other area just to flag, the IPR will be out in a couple of weeks, but it's not in your pack today. But we've seen some good progress in our cancer screening performance as per our trajectory, which you'll remember was a concern last time we were around the board table. So lots of areas I could talk about, but we'll leave it that we take questions from an operational and pandemic point of view. The only other point to add in times of uncertainty, and Lee and Berenice will update on planning guidance later. You'll all be aware of the delay to ICS implementation. Lots to think about in terms of what that means for us. But again, the collaborations that we continue to work on in Joined Up Care Derbyshire, really positive. And the last point to note, I know Jeremy and Lee just want to touch on our progress on the green plan in terms of where we're up to with that important piece of work too. Thanks, Helen.
Thank you, Angie. Obviously an important report to note, but this is also an important opportunity to ask Angie any questions colleagues might have, or to share any observations on the back of both what Angie said and her written report. I've got a hand up with Berenice.
Thank you, Helen. Just to add to Angie's thanks to the staff, they've been absolutely outstanding. And regards to the operational side of things, I think it's absolutely amazing that they've managed to keep 50% of our theatres running throughout. And they've not impacted on any of our urgent or cancer procedures throughout the pressures that we've seen. There's also been minimal impact on outpatient appointments, which is really outstanding. Angie alluded to the issue around the breast cancer screening, and just to add to that, as a result of previous board meetings and issues highlighted to us, a task and finish group has been set up, and there has been really good progress, and you won't see adherence to our standards as yet, but you can see them moving heavily in the right direction again, with a much improved trajectory from September 22, bringing that back to June 22 in line with the operational plan and guidance. So some really impressive work around that, but we're keeping a focus. Thanks for that, Angie.
And thank you, Berenice, for that additional bit of colour and flavour. Helpful. So Ian, please.
Thank you very much, and I'd endorse both the thanks for the previous presentation, but also everything that your whole team's doing, Angie. Really sort of humbling, I think. I had two questions. One was a sort of question looking forward as to you talk about in your report, effectively when mandatory vaccination is going to apply to the hospital, and just a bit more, I wouldn't mind a bit more sense and colour as to where we think, are there any specific areas of risk? What are the things that we're doing specifically in Chesterfield? Are there any things that we can learn from the effectively the care sector as to how they addressed it, etc., etc.? And then one might be my lack of knowledge, which is I'm assuming that COVID cases in wards, and the fact that we've seen you switching wards the whole time and doing all of that base takes out bed capacity as well, because you're having to reduce that capacity. So when I look at things like Midland Summary, our capacity looks unchanged, but I'm presuming, and I speak as a hotelier, it's almost as though you can't use those rooms, so you can't use those beds. So one of the other pressures on you is not only lack of discharge, people leaving beds, but actually beds actually becoming unusable. And I didn't know what percentage of unusable beds we had now.
Ian, they're very big questions, and I see Zoe's put her hand up quickly, but I know she's been close to the whole issue about vaccination. So can we take you on notice about vaccination and beds? Yeah, and I'm just going to go around to other colleagues, and then exec colleagues can come back. Jeremy.
Thank you, and thank you, Angie and Bernie, for your update. And I just echo Ian and others' gratitude for all the extraordinary work that's been done over Christmas and New Year in particular. I'm aware how very, very difficult it must be. Now, I just wanted to pick up on the point, Angie, that you said in your introduction about the green plan, because I, for one, was expecting that we would have that on the agenda today. There had been a requirement to submit it by the end of this week. That may not exist anymore because of ICS changes and so on and so forth. But nevertheless, as we have observed, the climate emergency is not put on hold because the ICS is put on hold, and it is an extremely important area of our strategic thinking that we need to get to grips with. So could we just have a quick reassurance that there is work in progress to bring a fit-for-purpose green plan to the board at the earliest opportunity?
Thanks, Jeremy. We'll take that one on notice too, and we'll come back to Angie and colleagues in a moment. Paul, please.
Thank you very much, and I also want to thank Angie and the rest of the staff and team for the great work that you're doing under what must be intense pressure. It must feel like being on a treadmill that's getting faster and faster as you get tired. So thank you very much. I want to concentrate on the people who are fit for discharge, and more strategically, rather than the firefighting that will be going on. Can I ask roughly what percentage of beds would be available? That's the first question. If people would be able to be discharged, so it gives us a kind of flavour of how acute that problem is. And secondly, at strategic level with the councils, what work is ongoing in terms of trying to unlock this problem on a long-term basis, because it comes around every winter. So things like step down, things like virtual beds and virtual wards, which are now being talked about. Can I just ask what work's going on there, and how long, if it is going to happen, before we see some strategic changes which will try to ease the problem in the medium to long term?
Thank you very much. I'm going to come to Christian, and then I'm going to go back to you, Angie, and feel free to bring in Zoe and other colleagues as you see fit in answering some of those questions in as far as you're minded to today. Krishna.
So I was just going to give it, so it's in part sort of answering some of part of Ian's question, really. So just some context for how busy the site has been. So it's not just obviously patients coming in, sort of some of the issues about discharge, but within the last 4 weeks we've actually moved 5 different areas. So we've moved acute frailty, we've moved our same-day emergency care area, we've moved wards to support movement to an enhanced offer for our respiratory patients, so that we could care for patients in a bigger environment when we're offering some more invasive respiratory procedures. All of that in the context of over Christmas and New Year has been incredibly busy, plus obviously the increase in prevalence of Omicron, but actually what's really hit us, which is the same sort of everywhere, is obviously about the patients coming in who are COVID positive, but they're not coming in with for COVID, they're coming in for another issue that happened to be picking up COVID. So that has increased. So we do test on admission, but obviously 3 days, 5 days, and patients are being tested positive is still, they've had it before they came into the hospital. It's just that the point where we pick that up, that has added to the operational pressures as well. So when Ian's talking about and how many, you're absolutely right. At the point, I mean, our IPC team, so Infection Prevention and Control team, have been phenomenal. We've got a 7-day service. We've had senior input over the weekends, all over Christmas, New Year. They've been absolutely phenomenal. Plus, we've had changes in guidance as well, which is obviously trying to keep us sort of a bit more reflexive. But our staff, our people have been absolutely phenomenal. They've had to sort of open up. We'd already planned to open a winter ward, but we pulled it forward because of the increase. And we've opened additional areas to try and accommodate patients. And this is against a backdrop of sort of high sickness levels. Again, this is, in keeping with everywhere else. We're not an outlier in that, but high and significant sickness levels. So when Sarah talks about our staffing paper later, it's an absolute testament to the staff of Chesterfield, just how they feel, that family feel here, and how they feel that they want to give absolutely everything they can, because they've gone above and beyond, and I can't sing the praises of our staff enough, really. It's been incredibly challenging, but the IPC teams have managed to flex so that we can reduce the number of COVID contact or beds that we can't use, and we've done an awful lot of work, certainly within the last 7 days, to try and make sure that we've got that capacity, because it's about balancing the risk of keeping those patients safe, but obviously we can't afford to have patients queuing or onboarding in our ED department, or ambulance delays, or people in our communities not being able to have access to ambulances. So it's all that run through. So our teams have been phenomenal in trying to sort of pull all of that together, and the operational team have just been incredible.
More very helpful context. Thank you, Krishna. Angie, can I pass back to you to conduct some further insights around the very specifics on vaccinations, bed availability in the trust, and bed availability beyond the trust, and how it is we're handling that, now and into the future, and finally also the item on the green plan.
Thanks, Helen. In true team spirit style, I'll ask Zoe to update on vaccination programme. If we could then go into Berenice on bed availability, internal and external. We'll try and do justice, Paul, to all the work that's been happening with strategically with our partners, but Berenice has been very involved in that. And if we can just add on John, specifically picking up the virtual ward work, and then Lee on the green plan, and I'm happy to mop up any further thoughts at the end. So over to you, Zoe, if that's okay.
Thanks, Angie. Yes. So mandatory vaccines, the work started in December in preparation for this being passed through Parliament, which it subsequently has been. Work's ongoing around our data, our records, and working with the IG team on that too, particularly around people who have been vaccinated elsewhere, to make sure our records are accurate and we have the information that we need. So we started the conversations with people pre-Christmas. Since the new year, in the last week or so, kind of more sort of formal letters, I guess, have been going out to people with some guidance notes to really sort of describe to people what support is available. So the ask of our leadership community is to make sure there's individual conversations with people if we don't have a record of them having been double vaccinated. Firstly, to understand if they have been elsewhere, and we just need to know so we can fill that information in. And then secondly, importantly, to understand what support we can provide for people, either to answer any questions they may have, or questions around accessing the vaccine, or any hesitancy that there might be. So that's ongoing. There's national support resources available, and also what we found has been really important since the vaccination programme first started is the local support. So we have people at the trust who have been sort of talking to people, which we've seen has been successful throughout, really, since the beginning. So since this was sort of mooted as an idea, have been talking with staff side colleagues and the staff networks and staff network chairs, and been kind of open where we are so far, and sort of asking for their support and ideas if there's anything we can be doing differently in terms of particularly supporting different groups. So they've generously sort of offered their support in terms of being able to talk to people, so people have a kind of a choice of folks that they can get in touch with, as well as the sort of national resources if they want to talk through any concerns that they've got. There's been some national guidance came out, which they've called the phase 1 guidance, and we're expecting the phase 2 guidance in mid-January, and that'll be more about the next steps, really. So the more kind of process side of things, and like I say, in care homes have sort of been through this process already. So we are expecting a sort of a national NHS approach in terms of, I suppose, the employment HR side of that, which we haven't received yet, but that is coming through. So I think what I would say is our focus is on the individual conversations and support.
Zoe, just so you're aware, the the national chairs WhatsApp group has been pinging since the early hours of this morning on issues about whether or not NEDs have been included in that vaccination picture, because most trusts have taken the view that even though a NED mightn't be doing a bed bath, that it is important leadership statement about vaccination, but also to enable them to do the board toward stuff. So if you haven't included us in your process to date, it might be helpful if you could going forward.
Yes, yeah. Absolutely, yeah. And like you say, it's not just about direct patient contact, it's about the sort of incidental contact, as they call it, which the example you've given, Helen, would absolutely be one of those.
Thank you very much.
Thanks.
I think you said we're going to Berenice next, Angie. Is that right? Thanks, Zoe.
Thanks, Angie, Helen. Krishna's probably described really in a lot of detail what's happened internally within the trust, and how we're kind of flexing capacity. And agree, Krishna, the IPC team have just been amazing, outstanding. I suppose the concern for us at the moment is that you know, to be really open and honest, we've got 124 what's classed as medically fit for discharge patients sitting within our organisation at the moment. And that has become a real challenge for us. Notwithstanding the amount of planning and focus that we actually put into our winter plan, where we recognised quite early that the transformation plan that was taking place across the county through the local authority probably wasn't, well, we knew it wasn't going to result in the capacity that was actually required to support the discharges. And just bearing in mind that we moved at the start of the pandemic from discharging patients within 24 hours to discharging patients within 2 hours of being medically fit. So a huge ask and a huge increase on the demand that was actually going to be required from social care. So we did actually go out and secure ourselves some additional residential care and nursing home support, designated beds for COVID patients that were being discharged. Early doors, we had a sum of 50 beds additional. We also, as an organisation, we commissioned some additional support for packages of care with an independent provider to try and assist with some of the delays that we had around that. Despite all the planning that was done, I think nobody expected the experience of, you know, up to 90 nursing and care homes being closed due to outbreaks and the difficulties with staffing that we've seen. The number of people who are leaving the domiciliary care market, so therefore the access to actual packages of care this year has been extremely challenging. So where Angie alluded to, we're having daily calls. We are working through this on a day-to-day basis to resolve some of these issues and actually look to open some additional community wards in order to support us work with the private providers to see if there is any other capacity. And as people will be aware of, there has been payments come down from the government as a kind of retention repayment for people in social care to say you are valued, and that's been kind of shared out already within Derbyshire to support keeping that workforce model in place. Paul asked about kind of future planning, because the last thing we want to do is get into this as we go through next year. We have got a robust transformation plan that is going to deliver additional capacity across Derbyshire for us. We are looking at more of a home first methodology where we're supporting more patients in their own home rather than having to put them into residential and nursing home care. So we've got to have a real push on that, and looking at the recruitment. And as part of that, it links into our earlier conversation about having employing mental health nurses into our frailty units and having that rotational post. We're doing exactly the same with our therapies and looking to rotate them so that we can reduce the level of risk and make sure that patients are supported back into the community. So I think, Paul, I'm probably not 100% answering your question, because I think a lot of it will come down to the level of investment, what comes out of the Social Care Act that we're waiting for more information to come down, the investment that there's actually going to be into that area. But I can assure you that we are, as a collective and across the system, working on this on a day-to-day basis, and we're also learning from some really good examples in Derby City, as well as wider areas. Hopefully that answers the question. Thanks.
That's very helpful. Let's go to John. Did you say Angie? John next? Good, glad I'm keeping up.
Thanks very much. Virtual wards. So firstly, I'll briefly give the chronology of virtual wards to board for those that weren't here at the beginning of the pandemic. When we had the original strain of COVID and Alpha and then Delta, the Trust had ADSTID Derby, a very effective collaborative virtual ward piece in partnership with Derbyshire Healthcare United, and allowing patients who still required low levels of oxygen to go home and be cared for. Our readmission rate was negligible. We had up to 20 patients on that ward, and equivalent numbers in Derby as well. As we've moved into Omicron, it's a very, very different disease. As a result of which we have 1 to 3 patients on our virtual COVID ward at this moment in time, and there's equivalent numbers in Derby. It's 12 to 15, I believe, yesterday. So why is that? That is simply because you either need a lot of oxygen or you need none. So that's the current state of play. However, more importantly, moving forwards, virtual wards is an exceptionally hot topic at this moment in time. There has been repeated engagement with clinicians, not just in respiratory medicine, but in other ologies in both of the acute hospitals. So this work is being led by currently the CCG, soon to be the ICB, but we are very engaged with our clinicians here at Chesterfield around this. We have had mandates from the Department of Health and Social Care to expand the virtual ward offer. All ICSs have had that mandate. And we are currently looking in how and when to do that, being very mindful of the strains and stresses on staff at this moment in time. I could talk about this for much longer, but what I would like to just summarise briefly is there won't be a knee-jerk response from Chesterfield nor Joined Up Care Derbyshire about deploying virtual wards. This will be done carefully. It does tie into what Berenice was just talking about delivery of care, supporting home first. It's not simply about shortening length of stay and getting people out of hospital. It's about admission avoidance, either in primary care or in ED departments as well. We're in liaison with the relevant clinical leads in all of those areas within the system and within the trust. So we will be seeing a development of virtual wards, but it's going to be an evolutionary process, not an explosive new way of working. So we need to be very careful about care, of course, about governance as well. So I'll pause there about virtual wards. If anyone would like to ask any further questions, please feel free to do so.
I think what we might need to come back to on the back of Bernice's item and yours, and indeed Zoe's to a degree, is, and it may not be possible today, but you know, if we're trying to quantify what this means in terms of bed availability now, bed availability in the future, and what that means for flow when you add in the kind of approach to beds in the trust, the approach with virtual beds, a better arrangement with local authorities and the community. So that might be something we need time to get to grips with. But if it is, to just understand how we might even scope that will be helpful. So just to put you on notice of that, Angie, before we go to Lee to hear about the green plan.
And just to say, Helen, that is one of the questions that SEC is managing from the system, because we could do something internally, but actually not looking at and picking up Jane's point in the chat box. It's the whole community piece. So we are doing that through SEC. I can't promise timescales on that, but we're trying to get that scoped as quickly as we can.
Very helpful, thank you. Lee, please.
Thanks, Helen. Bit of a history lesson for broader board colleagues just around the overall net zero agenda before I get into where are we at with the green plan, less helpful. So in October 2020, the NHS published a document around delivering a net zero NHS, which we've been reviewing and working out how we contribute to that agenda. Then that was followed up in June 2021 with a how to produce a green plan document with an expectation that every trust and ICS has got a consolidated strategy for each ICS patch by the end of March. It was hoped that we'd have had a board approved organisational plan by the 14th of January. We have written our net zero plan as an organisation. Importantly, I would claim what we're doing next is we're doing a comparison with all of those plans across the system to look at, are we all doing the best practice interventions, and having a discussion with NHSE around where the overall net zero agenda will be led from which tier, around national work on decarbonising procurement and other issues. So Jeremy's right to be suitably challenging about why isn't it here, but I think the next step around the comparison will be quite important. Very happy to bring it back to the next board and say, well, look, this is the document that we're QAing in the system space, and in submitting it to the ICS, we are the ICS. Jeremy's had an opportunity to comment on it. I agree with him, it's not quite fit for purpose yet, because we need to understand a bit better, have we got a common language across stakeholders? Are all our interventions best practice? And what support are we going to get at a sort of regional and national level? So apologies, it's not here, but there's a plan for the furtherance and the further development and the refinement of the plan, I would claim. But very happy to be challenged. Where we struggle very specifically is just getting it in the operational arm of the organisation meaningfully, as well as landing it at the moment, because it's one thing to write a strategy, it's another thing to engage 4,000 staff in its development, which we haven't done singularly well because of other events, I would claim.
Thank you. So we'll see the green plan in some state of evolution next time round. Do we need to take an action? Can I check with colleagues? Do we need to take an action that about the whole issue about beds? I appreciate Angie's answer that there's a lot of work going on in the system on this, but to have some visibility of what that looks like at this point in time will be helpful. And I presume we've had to give input in order for the system plan to be prepared. So even some visibility of that would give colleagues maybe a higher degree of granularity in response to some of the questions raised. Because I think what's behind the questions is, how is it we're getting the right amount of capacity in the system with, you know, with various options being brought into play both internally and externally. So I think what we've had today is a really helpful description of what's in train, but perhaps less ability to get our hands on what that means in a kind of planning and forecasting way. So how would that need to be best addressed, Angie?
I was going to suggest, Helen, and Berenice can kick me under the proverbial table if this doesn't work. It was all there in the winter plan, but maybe for board to just do an update on progress against that, because that was a point Berenice was talking about earlier. We didn't quite predict some things in the winter plan where others we did, but to make that really succinct as we can in terms of what that means in the hospital, what that means in the community, on a couple of slides rather than in a paper where it'll get lost again, if that's helpful.
I think it is. I think there's also something in the questions that have come through. So if, for instance, for example, we reflect on Paul's question, I think Paul's question is more than what are we doing with local government, but I think it's partly what more should we be doing with local government, and to what extent do we do that as Chesterfield Roy, and to what extent do we do that as system players, and what does that mean, if anything, that the board needs to be doing more of or less of or differently. So I'm all in favour of you distilling out from the winter plan succinctly what it is we need to be reminded of. But I think if there's steps beyond that, hopefully it will also tee up that discussion.
And that's why I was linking it to the winter plan, because I think that'll pick up that strategic point that Paul's making. So yeah, that's helpful. Thank you.
Thank you. Well, I always say that the strength of a report is not in what's written down or introduced, but in the number of questions it prompts and promotes. So an excellent report on all fronts in that regard. So thank you very much, Angie. That brings us on to the next item, which is the Freedom to Speak Up biannual report. Sue and I and Angie and a number of others get a regular opportunity to meet with Abby. So we feel we're kind of having an ongoing dialogue, but Abby does come and visit board twice a year, and this is one of the two outings. So we're very pleased to welcome you to the meeting today, Abby, and also very pleased that you brought Rebecca with you, and we look forward to the report. Do you want to tee this up, Angie?
No, just a reminder for Abby and Rebecca that board have had the paper. And as you say, Helen, this is part of the biannual submission we make to the NGO. So we're not going to go through the paper per se, but in our journey of freedom to speak up and learning what it means for our staff, a particular focus today on what it means for managers and to be spoken up about. And no pressure, Abby and Rebecca, but they did such a brilliant submission to the HSJ that we got highly commended. So this is a précis of their presentation for you all, and just to say to focus board on a bit of a conversation around those particular aspects today. So over to you, Abby and Rebecca. Thank you.
Thank you, Angie, and thanks, Helen. For those of you I've not met before, I'm Abby Harris, the Freedom to Speak Up Guardian. So thanks all for reading the paper. One of the key points I'd like to draw out from the paper today is how to keep moving freedom to speak up forwards to support everyone, no matter where they sit in the speaking up process. We've worked hard to raise awareness across the organisation, and most people now know what speaking up is. So our next steps need to focus on how we make sure we're supporting those who've been spoken up about too, so that they feel able to engage and then learning and improvement can happen. One case which really made me think about this involved Rebecca Sheldon, who's kindly joined me today to share her story. Some issues were raised to me in relation to Rebecca, who's the head of occupational therapy. I met with Rebecca's manager and shared the issue. We agreed that we'd work together to offer support to both the person speaking up and we thought to Rebecca too. We hoped that this would be seen as a time to reflect on whether there was an opportunity for some learning and improvement.
So, hi, I'm Rebecca Sheldon. I'm Head of Occupational Therapy at Chesterfield. So, in my 24 years of working at Chesterfield, I've had two experiences of freedom to speak up. And I think as a manager, the words freedom to speak up filled me with dread and fear, gave me a heart-sinking feeling to the point of last year in March, I tried to hand my notice in, which thankfully wasn't accepted. So when my manager first spoke to me about the freedom to speak up concern last year, again, my heart sank, I was upset, I was angry, I was confused, and ultimately I think I just felt a bit lost. I felt lonely, and it just came completely out of the blue to me, and I just couldn't understand it. So as a starting point, my manager and I met with Abby to really just try and understand the issues. But at that point, I was still really negative. I was really defensive about the whole incident and the whole freedom to speak up process, because I felt as a manager, I hadn't got a voice in that whole process. I felt it was all for the individual speaking up, and I didn't have a voice in any of that.
Thank you. So we'd agreed that Rebecca and Rebecca's manager and I would meet, and I was really pleased that Rebecca had agreed to that, although it was obviously really difficult for her. As most of you know, I'm really passionate about freedom to speak up, and I truly believe it's a good thing. It became clear during the meeting that I was really struggling to help Rebecca to see any of the positives, though. She was clearly hurting, and it was understandably really difficult for her to see past the process which she'd been through. And this was the absolute last thing I wanted. I really wanted to help her. I wanted to help her team. I wanted there to be some positivity to come out of it. And I was getting really frustrated with myself, actually, that I couldn't seem to help Rebecca to see that I wanted to support her, and I wanted to help her team see some positive change. But despite the reluctance, we carried on as we knew that we needed to sort something out. Rebecca and I reached a point where we agreed a plan that I could offer freedom to speak up manager training to her and her managers, and then a general freedom to speak up session, to the whole team. Following that, it's fair to say that there was certainly an element of apprehension on my part as to how this was all going to pan out, but I carried on to deliver the sessions with Rebecca as planned.
So working more closely with Abby over this last year, I think it has altered my whole thoughts and opinions around freedom to speak up, and also about, as a manager who's been spoken up about, I feel I've had the opportunity to speak up, and more importantly, I feel I've been listened to, and had the opportunity to help shape the future of speaking up in the organisation. I've been listened to by one of the execs who had an exec visit. I spoke to them about it, who gave me some advice about where to go with it. I've spoken to somebody else. So I just feel I've been listened to. And I've actually been able to work with Abby and my OT leadership team to roll out the manager's handbook. We've run the awareness sessions in the department. I feel that by doing that, it's just led to, it's enhancing that positive speaking up culture within the department. And I think one of the biggest learning points in it is that everything is classed as speaking up, even the positives. It's not just about freedom to speak up is just going to Abby with a problem. It's about how are we creating that culture within the organisation that everything is speaking up and everything is welcomed, and all the positives within that as well. And then since the session that we then ran in the OT department, I've had some members of staff come to me about a piece of equipment that they feel that they need, and we've been able to action that, get that sorted. We had somebody come to me about some concerns around a certain patient pathway where there was some harm coming to patients. We've been able to address that as well. From the sessions, I've had 2 members of staff want to be freedom to speak up champions. So I think already that training and a more positive outlook for myself with the staff as well has had that impact on the staff, but also on patient care as well.
So I was really pleased to see that Rebecca was feeling better about freedom to speak up, and she'd really, as she said, we really engaged with each other, really engaged together, and in both the manager session and the wider team session, and we've seen, as Rebecca's described, such positive results from that. A little while after we'd worked together in these sessions, I'd gone to a pre-arranged meeting with some other leads, and Rebecca was at this meeting as well. And in this meeting, I was explaining how I could support managers and their teams in different ways. I decided that I would take a chance and ask Rebecca for her feedback on the sessions. And up to this point, I hadn't heard how things had changed for her. So her response was music to my ears, and I was genuinely beaming in that meeting, because as a result, most of the leads that were in it got in touch with me afterwards and asked me to run similar sessions for their teams, which is again spreading the positive learning further across the organisation, and that was absolutely thanks to Rebecca's feedback. So this whole thing was a time of real reflection for me on how we make sure that we're supporting everyone. So next steps for us at the moment, starting next week actually, include Rebecca being involved in a review of our freedom to speak up policy to make sure that in order to keep working towards that positive shift in culture across the organisation, that we're appropriately supporting those people speaking up, those people who are spoken up to, and those people who are spoken up about. So just wanted to say thank you so much, Rebecca, for joining me today to share our journey, and thanks all for listening, and I'll pass back to you, Helen. Thank you.
Well, goodness me. Rebecca, you gave the impression that didn't take anything out of you at all. And I'm absolutely sure that even talking about it all again today, despite the journey you've been on from feeling very negative about it to feeling very positive, is a big, big step. It really is. It's extremely generous and enormously mature of you to come and describe the journey you've been on in the terms you have. And it speaks volumes to your leadership and embracing this whole way of. So thank you so much. It's also been very further revealing about you, Abby, because you've had huge success through the Freedom to Speak Up programme, as is evidenced every time there's any other league table sent around about how well it is we're doing about getting colleagues comfortable with speaking up. And we knew you were doing a very good job, but to see the extent to which you've really embraced all parties in freedom to speak up cases and been so authentic and genuine and determined to make sure everyone going through the process is supported was lovely to get a flavour of that at first hand. So a huge thank you to both of you. Now, there will be lots of comments and thoughts, I feel sure, and appropriately Sue's hand's gone up because Sue has taken over from Beverly as the NED lead for Freedom to Speak Up. So over to you, please, Sue.
Thank you, Helen, and thanks very much, Abby and Rebecca, and yeah, echo Helen's comments. It's great to hear the outcome, but thank you for sharing that because it will not, I'm sure, have been easy. I love Abby's completely refusal to give up and keep going, which is wonderful. And as Helen says, lots of great things, but it doesn't come without effort, does it? And we don't always see that. So it's lovely to have just heard that story. I just wanted to just comment very quickly on the report. I'm sure everybody's read it. It's always easy to read and a joy to read, but particularly pleased to see the range of ways in which you are making it accessible and visible and communicating it into the trust. You would almost have to have been in a coma to have missed the fact that we think this is very important. But it is really key to have all those different mechanisms, whether it's your, well-being and a cup of tea working with Andy, or whether it's your tree that you had, or, all of the different things are really important to kind of embed it as a systemic thing, not an initiative. So I'm very grateful for all that effort of all of those different ways. You've already talked a little bit about, because as ever I would say that's all great and then so what, as I often say. So I think you've talked about one of the so what's is a policy review, which we're down to do anyway. I just wonder if there's any other things you could talk to us about the learning from this and how else we might make sure we don't miss any of that gold dust. And then the final question is just what would your ask be of board really in this difficult time that everybody's having in the NHS? Is there anything, any kind of nugget from Abby, which is about what you need from us and how we might best help in this next kind of period on freedom to speak up? Thank you very much.
There's quite a lot there, so let's go back to Abby directly on that before I come back to Nora.
Thank you, Sue, and thank you for your positive comments and your support. So learning from this, as we've said, the paper is one of the main things, because what we also know is that the policy isn't just for me to follow, it's for us to follow as an organisation. So it's really important that we've got that policy right, so that whoever is being spoken up to if you're a manager who's being spoken up to, you can refer to that policy so you know how best to support everybody with it, so that the policy supports you as a manager, but it supports the person being spoken up about, the person speaking up. So it's really important that as an organisation, whoever is being spoken up to knows that that policy is there and knows that that policy is fit for purpose, and that it's got that support there for everybody. So I think that's a really imperative is the word I'm looking for, thing that we need to get going with that, and we need to get that right, I feel, and then for that to be, for everybody to know about it, for everyone to know that that policy exists, and to really promote it as well. So my plan to promote that policy once it's as I want it to be, is to promote it through the Freedom to Speak Up for Managers training, which I am still aiming to. It's slowed down a little bit for obvious reasons with everything that's going on at the moment, but my aim is still that I would like every manager in the organisation to have that Freedom to Speak Up training, and make sure that within that we're talking about everything we've talked about today, and that we're making sure that people know that that policy's there. So that's sort of the learning really from that, the further learning, and that just as an organisation, as leaders, we're all supporting and promoting that movement. And that, I think that's what I would ask from board is to continue to support and promote all of this alongside everything that you all already do. Everybody at board is so engaged with me and so engaged with everything I do, and they all do it with me, which is so important and so much part of spreading that news and that. And I think, you know, I've been somewhere with every exec over the last 6 months. I've worked with every exec. They've all come away with actions, bless them, and they've gone off and done it and fed back, and that's all part of the speaking up process. So even though that doesn't translate as a speaking up case necessarily, there's still actions that come from these listening sessions that we do together in various teams, and then people can see from that well, I've spoken up to an exec, they've gone away and they've taken an action, and they've come back to me and they've told me what that action is, they've told me the result of that, and that just kind of shows it even more, and it's leading by example. And I think that's leading by example bit, that's probably my nugget, leading by example.
Thank you, Abby, that's great.
Thank you. Nora, has your hand gone? Oh no, there you are, Nora.
Thank you, and thank you for those insights. It was really just a point of clarity on the report, if I may, Abby. On the themes of by cases and by division, the two kind of largest spikes there are communication attitudes and communication other. Can you just give me some insight as to what that's actually tracking, and then what are the areas that we're doing to mitigate those round about that? And then it was just a question in comparison Chesterfield against Sherwood and Rotherham, and why our cases seem to be sort of trending higher, although beginning to fall, and if that is coming just because there is more awareness of the whole Speaking Up initiative, and what you would expect in terms of trends moving forward.
Thanks, Nora. Let's go back to Abby on that one too.
Thank you, Nora. So in relation to the communication side of things, so as you say, one of the themes around communication is attitudes and behaviours, and the other theme around communication sort of covers everything else. So it can be things along the lines of lack of communication, or style of communication, or just really anything along those lines that can sort of sit under communication, that people would share with me and say, you know, I've not heard about this, or I've gone to that person and they've not done anything, and actually they have done something, they've just forgotten to let the person know about it. So that sort of involves an element of communication there. In terms of what we're doing about that, so there's lots of I know sort of there's been some difficulties again with things being being paused, but I know I say this every board I think about. It's always going to smile when I say the words human factors. So we have human factors training now across the trust that's available for everybody to access, which really focuses on the importance of communication and patient safety. So that's one of the things that's definitely happening. Again, it's sort of, at the moment there are just issues with people being able to attend training. So that's one of the things that we're doing. There are, in terms of attitudes and behaviours, so that's, as well as that being an issue in our organisation, that is also in line with the national picture. So we're not sort of exclusive with that issue. That's the main theme across the country that the National Guardian's Office sort of has shared across the country. So what we're trying to do with that, there's groups that exist. There's a group that exists, which is a Respect and Civility group, which is trying to look at ways to address these issues across the organisation. They were heavily involved in Anti-Bullying Week in November, and there were various things that were going on within that week to really highlight kindness, ways to talk to each other, the importance of all of that kind of thing. The head of HR and I have we haven't developed, that's not true. We've borrowed from another organisation and adapted it to suit ours, a civility in the workplace session, which we introduced in Anti-Bullying Week, and we've been asked to start rolling it out in different teams. So we're hoping to start that in February, all being well. So there are some of the things that we're doing to address those issues. And then in terms of our number of cases in comparison to other organisations, so we do have a higher number of cases, and for a little while that did make me a little bit nervous as well. So I spoke to the National Guardian's Office about that, and they explained to me that if that's happening in conjunction with other indicators which suggest our freedom to speak up culture is improving, then the high number of cases is a good thing. Whereas if we have a high number of cases and other indicators suggest that we have a more negative speaking up culture, or one that's deteriorating, then that's more worrying. So as long as our high cases are going up along with the indicators, which a lot of which are taken from the staff survey results to suggest that our speaking up culture is improving, then we're on the right lines. At some point we would expect, it can't go up and up and up forever, so at some point we would expect that the numbers of cases will drop because less people will be coming to talk to me, because more people will be talking to their managers, which is how we're trying to affect the culture change, because we want people to feel safe to speak up directly to their managers. And so I wouldn't know about that necessarily, but what we would see is that across the organisation we'd hear that people are feeling safer to do that, and we'd see that reflected in the staff survey results as well. Does that answer your questions, Nora?
Yeah, that it would also probably suggest to me that in terms of behaviours and civility, that's maybe something that we should be looking at maybe more for inductions as well, about expectation round about behaviours, so that we set that stall right at the outset. But great to hear that people are now speaking amongst themselves and with managers rather than having to come through a third party. That is good news, so well done.
Thank you.
Ian.
Thank you. I'd endorse all the comments, and that's particularly the point, Rebecca. That was very brave of you to give us that example, and it's always a really healthy reminder to boards that things that look on the face of it in one way, actually, that's how they felt at operational level. I guess Nora's just made the point about induction, so I was saying one of my questions as to how do we ensure that freedom to speak up and all of the dimensions are in induction, but I think you just covered that. I guess the question I had on your report was around RPC, which is obviously there are 152 people there, and they're geographically diverse. And we've talked about benchmarking to Sherwood or to other sort of hospitals. I guess it's how do we sort of, in a quite a challenging environment, make progress around the RPC, and are there any other things that other CCGs or ex-CCGs that we can learn from to help us in that area? So thank you.
helpful comment, Ian, and I'm sure Abby will take that one away. Jeremy.
Yeah, thank you very much, Abby and Rebecca. One thing that struck me reading your excellent report is on the figure 6 on page 7 of your report. The proportion of people from the allied healthcare professionals group speaking up is significantly lower than any other group. It's 0.3%, and the others were 1.1 up to 2.8%. And I wondered whether, if you could just relate that to what you've told us, Rebecca, about your experience. Is this a timing thing? Because I know that relates to April to September last year, and I don't know when your experiences were. So I just wondered if there's a connection there between them.
Yeah. Experience was the year before, at the beginning of last year, wasn't it, Abby?
It was, yeah. So in terms of the figures for the allied health professionals, it's sort of, obviously you're quite right, there are less of those that's the lowest group of people definitely that are speaking up in terms of those percentages. I think it's it can go in fits and starts, and when there's a smaller group of staff, if a few people speak up, that makes the percentage look really big, even when it's just a few members of staff within a smaller staff group. So what I'm trying to do is make sure, I've done lots of work actually with allied health professionals, a lot of it off the back of speaking with Rebecca, with some of her leads, her colleagues. So we're making sure that allied health professionals are aware of it, aware of what speaking up is, aware of how it can help. I've done drop-ins there. I meet regularly with the head of therapies, working with the teams, the team leads again doing the manager training and offering to do the wider sessions. So it's a case of really sort of keeping up any areas where I'm hearing less. It's about sort of, is that a good thing? Is it a bad thing? I need to make sure one way or the other. And if it's a good thing, that's great, but it means they're speaking up where they are, which is brilliant. But I need to make sure of that myself. And just going back to Ian's point about RPC is another area that, as we said, I don't hear very much from. It's been a difficult place to get to over the last year, just because they've needed to reduce footfall and people have worked in different ways in RPC. But I did meet with Joe Lacey, whose job title I can't entirely remember, within RPC, one of the leads in RPC, and we have come up with a plan to support the team and to engage with the team. Some of that is with Andy Pickin, the health and wellbeing lead, where we're going to do some joint work together. Some of it is me on my own, and that's engaging with leads. A lot of it's probably going to be virtual, apart from the sessions that I do with Andy, just because that's what's going to work the best for their area. And we're looking at how we can sort of really raise awareness. I've got one Freedom to Speak Up champion in RPC, but we want to have one for each area and one for each profession, so that people can, they have that accessibility and availability. And somebody who's spreading the word that they're comfortable talking to as well, who can signpost to me as needed or signpost to managers as needed. So that's sort of how we're bringing in RPC. Does that answer your question, Jeremy, and your question, Ian?
Yes, it does. Thank you.
Very good. I think it just remains to say a big thank you again to both of you. It's a very comprehensive report reflecting a lot of very hard work, and we should be very grateful to be in the position we are in. That's in no small part, not only due to the energy and enthusiasm you bring to the work, Abby, but also the thoughtfulness with which you discharge it. As for you coming today, Rebecca, well, I can't begin to tell you how much we appreciate that, and how lucky we are to have leaders like you in the organisation, who are thoughtful and responsive and always looking for ways to improve the leadership of your team. So a huge thank you to both of you. And I know there'll be many conversations with Sue and myself and Angie and other colleagues between now and the next time we see you aboard. But we very much look forward to seeing you aboard in another 6 months, if not before.
Thank you.
We're now about to go on to item 5. And item 5 is the Nurse Staffing Establishment Review. Krishna.
Thank you very much. So by way of introduction, Sarah Ward was, well, we were very pleased that Sarah was actually applied and was accepted onto the Chief Nursing Officer Fellowship for Safer Staffing. And as part of that, she's led on the work of the Nurse Staffing Review. So I'll ask Sarah to present, not present her paper, but to talk around the key points. Thank you, Sarah.
Thanks, Krishna. And hot off the press this morning, I have successfully completed that fellowship with all the academic requirements passed. So good news there. So thank you for that. We've heard loud and clear, I think, through the course of the meeting so far, the context in which we're all working this morning, and all working throughout. And so this paper covers all the principles of the statutory requirements considered as part of the review, accepting the multiple reconfigurations and pathway changes that we've had to put in place throughout. What it has done is enabled a reflection with our ward leaders on how we've maintained patient safety through our prolonged escalation response. And of particular note has been the effectiveness of our pool ward concept. This has enabled dynamic deployment and redeployment to respond in real time to changes in ward acuity and configuration. And whilst the guiding principles of this have been patient safety, you'll note from part 11 that this has also been cost effective. This has been managed via the components of a staffing hub, which we'd like to develop further in the future. We know that the consistency of using our own staff, trained to our own standards, has a positive effect on patient quality, patient care quality. So the final point I'd like to highlight from the paper is how we align the learning from the winter escalation assurance, which is in Appendix 3, and invite a discussion on our approach to future funding of winter ward nurse staffing. And I'll stop for any questions.
Very helpful and delightfully succinct, supported by a very helpful paper, Sarah, so thank you. We've got a number of colleagues who'd like to come in, so if I go to Jane first, please.
Thank you, Sarah. So just from the paper, I was encouraging both Krishna and Sarah to think about this question about the winter planning and staffing, because we do know that where we have teams that don't regularly work together, where we bring in outside staff, agency staff, etc., that actually the quality of care suffers. And that's not only about experience, but it's also about clinical effectiveness, and it's also about safety. So I'm just encourage us as a board to really just listen to that point that Krishna and Sarah are making, and for us to think about that going forward, because I think it is really, really key. We previously have had models where we didn't have the level of staffing for those wards within our own capacity, if you like, and actually we really did have some really quite adverse outcomes previously. So I think it's a really, really important point that they're making, and I think it's a really important thing that we consider.
Thank you. Sue, your hand was up and it went down. Was that just trigger happy, or did you want to come in?
It was a bit trigger happy. I'm fine.
That's fine. Okay. Berenice, please.
Thank you. I just would like to support everything that Jane's said about the winter staff, and there was a real aim this year to plan ahead and put in adequate resource, and indeed the team in medicine definitely recruited additional matron and sisters to be able to support and really lead the winter ward, so that we didn't have kind of ad hoc arrangements, and that has been really effective. I think, as Krishna's described, we've then had to expand further, and given kind of some of the pressures that we've seen on the staffing levels that were certainly seen in the first phases of COVID outbreak. That's been much more challenging. So I think the plan was to make sure that we actually had that resource. We built that into our overall levels, Jane. But also it really helps with things like the training, releasing people. You've heard on other reports we're constantly having to cancel training and not release people. Frustrations from our emergency departments about being able to access their trauma training all the time. So just to have that additional flex really will assist us in providing safe care and developed care across Chesterfield. So really support that.
Can I ask, would we be one of the few trusts in the country that are receiving a report to board providing assurance about staffing levels across the trust? Now, I appreciate there's a number of individual reviews going on in specific areas and that you'll want to come back to us with those, but setting those to one side, would we be one of a very small number of trusts that's receiving this assurance given all the other pressures on the trust at this time? And if that's the case, to what do we particularly attribute that success?
Through my fellowship faculty, actually, the fellows that have been through there, the faculty are all taking reports to board. So I think the measure of the success of the faculty and the focus on safe nurse staffing, I think, has encouraged a real focus at board, despite pressures.
Yeah. Thank you, Sarah. So can I take it that we're like to Sarah, like everyone else who's come today, I'd like to express our huge thanks and appreciation. It's close to magicianship, this, and let alone nursing leadership, to have achieved what you have in the circumstances, and we're very grateful, and we accept the assurances that we've been given in the paper, and we look forward to the individual reviews as promised coming back at a future date. So I would summarise it there and leave it there unless Jeremy has something pressing to say.
Well, I just wanted to pick up the point Lee's put in the chat about the volatility of the care hours per patient day figures, because it's something I noted when reading the paper. On paragraph 4.2 on page 4 of the report, I wonder if you could elaborate on that a bit.
Thanks, Jeremy. Yes, it's a good question. So that has been seen nationally. So we have seen a reduction in care hours per patient day nationally, and that is explained by the additional areas that are open. So our resources spread more thinly. So hands-on patients is less through that, but it has seen us drop from the upper quartile to the lower quartile, probably indicative of additional surge areas. ITU is a good example of that. In larger trusts, you will have an area that can flex, but we've had to open across 3 areas, which is, you don't get the economies of scale. So that's probably explaining that anomaly.
Thank you.
Thank you very much. And thank you again, Sarah. And congratulations on your award. Very good. So let's go on now, if we may, please, to item 6, which is the operational planning update, and we're having a duet from Lee and Berenice.
We'll try not to sing, Helen. Thank you very much, and yeah, absolutely, we'll take the paper as read. Many thanks to Claire Hinchley, our Associate Director of Planning, of Strategy and Transformation, for pulling out the key points from the operational planning guidance that we received on the 24th of December as a nice Christmas present into this paper, because it sets it out very clearly. We are still at the point where we're waiting for the financial guidance, but I will ask Lee to kind of input on the financial side of things. But we do recognise that it'll be 1-year revenue and 3-year capital. That isn't impacting us on our priorities setting as an organisation, and our thoughts are very much about how can we plan better and not see another winter like we're experiencing now. We keep, every year it goes from this is the worst winter we've ever experienced, and then the next year we say it again. So what we want to be saying next year is that this is the best plan for winter. Claire has very helpfully set about arranging some planning days for all of our divisions, where she will take them through with clinical input, which is what is really important, that they look at the services that they're delivering. They've done some horizon scanning themselves. They've reflected on the operational guidance, and they are setting out their priorities, and they will be set about for the next 5 years. So the planning days are set for the end of January, beginning of February, but that will be the start of the process, and we'll really button that down. I probably just want to say a couple more things just around this is a bit of the start of the journey, because we are still waiting for more information. You'll see from the paper that we still haven't got the plan set out from our CCG on the meeting schedule and how they're going to pull that information together, but that will happen from now up until the end of March, so that we can have that submission early April. The other point just to say is we have received the draft standard contract through as well, and there are pertinent points in there that are reflected from the operational guidance. It is for consultation, but it does mention, rather than having our 4-hour standard, one of the things that they're looking at is really pushing the 12 hours experience in ED and moving back to a 98% standard around that. A real push on that continuity of care for a carer as part of the Better Births and Saving Babies' Lives piece of work, which is excellent. What's really helpful is that health literacy. So we talk about communications, but really improving that communication with our patients so that they really understand some of the messages, and we see some of that through the complaints that we've received over the recent months. So I think it's really helpful to see that contract, even though it's for consultation, is really reflecting some of the guidance, and there's no surprises in there at all. A lot of work to do. There's a lot of asks again of the acute trusts, and it really pushes that system working even further, because if we don't start pulling this all together, we're never going to achieve some of the asks in there. I'm just going to hand over to Lee to say anything that he wants to on the financial side, and then just happy to take any questions. Thanks, Lee.
So we're still trying to interpret the parallel document we received on Christmas Eve about what the financial settlement is for 22-23. The sort of headline message is there's around a 30 million cash reduction 21-22 to 22-23. So that is a net cash out number that doesn't cover inflation and a range of other things. So despite all protestations that it's all going to be rosy in the garden, one could easily claim it might not be as rosy as all that. However, embedded within that is quite a heroic assumption about the reduction in COVID costs. And we're currently doing a piece of work to track down, is our COVID allocation equal to the costs of COVID? Because that's a large part of that cash reduction. So if COVID continues, it is highly likely there'll be additional conversations with the Treasury about maintaining that funding. But absolutely, we will need to get back on track a whole range of system-based, I would urge, redesign initiatives around care outside hospital, the integration agenda, which we're working on. At the moment, the system planning cell, the system DOFS meeting, is starting to put together an overall system framework for how we're going to bolt the plan together between now and the end of April. So headline message, the money looks a bit scary, not as scary as we'd previously anticipated for financial year 19-20. And there's going to have to be this pivot moment when we manage to engage more fully operationally and clinically from critical incident response to, crikey, what's our strategic plan for care outside hospital and changing our models of care, which obviously is going to need some sensible handling in the context of what's filling the frame at the moment versus what we need to try and fill the frame in the context of a 22-23 planning process. But I think that's more than enough from me in my not so Pavarotti role, Helen.
Mellifluous tones, nevertheless. Thank you. I mean, I appreciate the headline isn't 30% more with 30% less, but you could be forgiven for reaching a point that's not far off that. So, as you say, it does put a lot of pressure on not trying to go faster to achieve the impossible and finding new ways of doing things. And you've asked for two things in the paper, as I recall. One is for us to note what it is we're asked to do, and number two is for our support in your proposal to have a very engaged and engaging process through the divisions to work out how it is we're going to do it. And I feel sure that we will all be happy to support you in that. In the absence of any hands, I wouldn't mind leading off, though, with the first question, really, which is, there will be very elaborate ways of monitoring our progress with this, I feel sure, at divisional level and through, other channels. What, if any, additional or different indicators or measures might we need at board in order that we as board can be held to account for making sure that this plan gets delivered? So will the usual reporting we've got through the IPR and other mechanisms be sufficient, or will we need some planning of board level milestones that tells us whether we're off or on plan with regard to these asks?
Do you want me to have a go at trying to answer that, Helen? It may or may not be the perfect answer, but I'll have a go. There's a conversation absolutely taking place in the system space at the moment about a very robust, my view, document we've got about how would we measure a more plural series of outcomes as a health and care partnership, which I think is a very positive piece of work, which looks more plurally at health and well-being. We're then having a conversation about, have we got the right scorecards for the main programme boards, planned care, urgent care, mental health and learning disabilities, which help us to see what are we anticipating to do differently through those programmes which will contribute to that outcomes framework. Yeah. I think when we've done that piece of work, we'll then need to understand the change programmes are going to alleviate capacity pressure, workforce pressure, a range of other things in this way. So I think when we've given a bit of consideration to your very sensible question, Helen, I think the headline answer will be yes, but I couldn't quite explain it to you yet, but I think we do need to get into a slightly different place about how we looked through the IPR gates inwards for CRH, and how do we look outwards in a more plural change programme sense to go, are we making the appropriate contributions to the changes we need to make around care integration, alleviating medically fit for discharge patients, changing the way we do chronic disease? So I think the broad answer is yes, but I couldn't quite explain to you in real time as of today's day, and it would look like this.
And the only thing I'd add to that, and it's great that that's in train and that you're taking a way to think about it further, but it's a bit like the conversation we had earlier in the meeting about bed availability. Yeah. It's really important that we work as a system, and we can only work as a system in this regard, but we're also accountable as a trust, and the trust is the sum of the parts of the system. So we need to understand whether our contribution to the system is on track or off track, and we need to understand that in a way that we can be responsible and accountable as a board. So that is, that's increasingly the position we're going to find ourselves in. So we don't need an answer today, but I feel sure that we do need to work it out sooner rather than later.
And Helen, can I just add also, because this very much links into the conversation that we're having about the delivery boards. So I absolutely think that this board should be cited on what we're doing, but it's that bit about reducing the duplication and making sure that we're collecting the right information that reassures our board as a legal entity that we're hitting all of these areas, because we are being measured by them. So Lee and I will certainly take that away, and we'll work with Claire and the planning team around how we bring that back in a proposal.
Thank you very much. Paul.
Thank you. You've said a few things I was going to say, Helen. Just some questions, maybe naive questions, but questions all the same that I think need asking. The list from NHS England about the priorities for the next 2 years is cloud cuckoo land list, as far as I'm concerned, in terms of the reality of delivering some of those things. It might be aspirations. So in terms of the trust, which are the priority ones from that list for the trust that we need to focus on in terms of improving patient care and doing our bit both internally and externally for the system? Where would we prioritise? Not saying that we won't do everything, but where would we prioritise? Or if we did all those things which are on that list, what would have to be deprioritised? Because I'm not clear, because it seems a long list. The second question is comes back to one Helen said regarding reassurance. The one thing that I've really not got my head around it, and I'm only a month into the post, is as part of the outcomes of the improvements and all the planning we do, where do patient outcomes sit with that, and how do we monitor that in terms of what goes into the plan, what we plan, the patient experience, and how does it come out, and how is that measured? Because I see a lot of service change, which is we just continue doing the wrong thing a little bit better, rather than we really understand what it is on the patients. And the third question is quite, I'm not sure whether you'll be able to answer, is having read the paper and having listened to what you said, I still don't understand how the divisional planning leads not just to what we're doing, but literally how it feeds into the system, how the system feeds into what we're doing. It just seems disjointed. Now, clearly we've got to plan internally, but what's happening externally and what we want to achieve with our partners. So where I don't get a feel that the bigger picture's there in terms of the planning process. And it may be that it's not ready yet, but I just need to be assured that if this is the process that we're doing, that really is taken into consideration, because I feel a little bit worried that it's not coordinated at the moment in the way that I would expect.
Thanks, Paul. Let's go back to Lee on that.
So I think, Paul, one of our neighbouring Derbyshire NHS organisations has had a similar cloud cuckoo land response to, we can't do all of that. It sounds like the planning guidance is getting us to try and jump even higher, do a sort of high jump over a sort of pole vault size target. So their conversation, which I think we've got to mirror within the organisation, is what are the things that would most easily enable the delivery of this plural range of objectives, which very understandably are being set for the NHS at a national level? And my answer to some of that is around the thing that will alleviate some of our crises around workforce shortage, the thing that will alleviate a crisis around general and acute bed usage will be, how do we ensure the general and acute bed stock is being used efficiently as it can be for those patients that absolutely need to be there? So what is our plan to ensure we are down to a much lower rate of medically fit for discharge patients? How will we do chronic disease and frailty in a different way? And I think what we've got to do is change the 10 asks to some extent into something that works for us as a system. And then there is just a candidly messy triangulation into the system plan and the divisional plan about the divisional contributions to those plans, even though there will be areas where we can improve clinical and cost effectiveness of our own service portfolio that isn't reliant on the system. So that's my attempt at an answer to your question, Paul. But I think some of us in the service did see that document as a little bit of a slap in the face in terms of when it landed and the overall level of expectation in it. It is true.
Angie, I suspect you might well want to come in on this, so let's go to you next, please.
Just to add to Lee's summary, there overlaid on that is the requirements we're still getting from NHSE to achieve something different by the week. So, for example, we've been given a target, or we were given one just before Christmas, about reducing our medically fit for discharge patients by a certain percent, and then a week later everyone says that's completely unrealistic, so we get another figure to do it again differently. And my struggle with it all, I think is what Paul is saying as well, is how does that fit strategically into what we need to focus on as an organisation, while still managing and supporting our teams who are having to submit these returns and get their heads round, well, you told me to do that yesterday and now you're telling me to do this by tomorrow. And it feels like the NHS is doing even more of that at the minute, possibly reflective of the pandemic, but also a little bit about that different steer from the leadership that maybe we had from those who set out on a certain path previously. And we've just got to give ourselves time as a board to reflect on how best we support the staff with that bottom up, with the top down, and somewhere in the middle, hopefully try and get that as best as we can.
I think that additional response, Angie, has been really helpful in bringing into stark relief what the role of the board is in all of this. There's a really big role for the board here. So I think the questions I've asked about monitoring and the questions Paul has asked about planning are, arguably two sides of the same coin. But there's something about ensuring we've visibility of those matters for which we're accountable and ensuring we're delivering the best outcomes by virtue of working with and through others. So I wouldn't encourage you to rush to answer them. I'd encourage you to give them some really good thought so that we can then come back and make sure that we kind of do justice to this, because we understand and appreciate that's going to take a bit of time to work through. Jane, your hand was up.
I think the points were covered, Helen. It was really about, Lee mentioned something about scorecards, and normally I gasp at scorecards, but actually I thought that is something about rigour that I think has been lacking. And I think in terms of driving forward the transformation plan, overlaid with planning guidance, overlaid with what is our part in the system, there is a bit of rigour, and whether we're looking and measuring the right things so that we can actually evidence progress, that I think is really critical and has been lacking.
Very helpful. Well, let's use that as the summary for the item, Jane. And with regards to the paper, we note the targets, and we commend your inclusive approach to the planning, and we would ask you to do as we've said about making sure we're getting appropriate parallel planning with the system and good level of board level metrics so that we can monitor and be appropriately accountable for delivery, preferably in outcome terms rather than input terms. So thank you for that. That was a great item, and I'm sure will dominate much of our discussions for the next 12 months. So we will move on, if we may, to item 7. And this is your data, digital and technology strategy, John. And again, please feel free to take the paper and your slides as read, but a steer on the sort of conversation you want to have now will be welcome.
Thank you very much. So this is a renamed strategy. In times gone by, those that were here in 2019 will have known it as the ICT strategy. There are some key messages within the paper and some recommendations. I've been very aware that there has been a large change in those of us attending this board, so there's also quite a significant historical context in there, particularly around the roadmap, for people to be able to see what we've done as a trust and how we've increasingly worked as a system partner within the confines of Joined Up Care Derbyshire. And there are governance and assurance processes in the paper at both a trust and ICS level. The timing of this paper is fortuitous. I am asking that we bring this back annually for review, but always give a 24-month forward working view of where we're going with DDAT to ensure clarity and transparency. The recommendations are to receive and ratify the strategy, which focuses significantly on levelling us up, if I'm allowed to use the phrase, to get the relevant HIMSS level that we're required to do by 2023. And the core focus for that, as well as keeping the wheels on the bus and keeping us safe, which is also in the paper, is to move forward now the Trust is ready to have an electronic patient record for notation in ED, on the wards and in outpatients. And we're working forward to that. I've also tried to explain our integration into the current work streams of Joined Up Care Derbyshire within the paper, and to give some context regarding the relatively chaotic funding processes that have been in play for the last 4 or 5 months. So I'll pause there and see if I can attempt to answer any questions. Thank you.
Thank you very much. Keith, I wonder, could I go to you first on this? I can't see you, but I presume you're there somewhere.
No, I am here. Sorry. I've been having a few camera technical issues, so let's move past that. Sorry, Helen. Yeah, John very kindly shared this with me in his production of it, and I think it's a very credible plan. I think it's starting to show also, which I think is really important, Helen, it's starting to show what is part of the Joined Up Care digital priorities jointly across the wider system, rather than just focused on Chesterfield, which I think is increasingly important for us, both from a practical point of view, but also, if I'm honest, from a funding point of view, because some of that funding is increasingly going to become from a system funding rather than directed at an individual trust. I think it shows a huge amount of progress. I think we have to be reasonably realistic with ourselves in some of the stuff that we haven't been able to do because of what's gone on in the last 18 months. And I think, ideally you'd want to look at that chart and see everything to the left of 21, 22 is green. It's not, but I think there are very good reasons for that. And I think we need to be realistic with ourselves. But I think we're going to get increasing levels, and John and I've had this conversation from John, we're going to get increasing levels of challenge, I think, both in terms of system integration with the wider system, but also what that means for Chesterfield and what we have to do in Chesterfield in order to integrate into that wider system. And that isn't going to be, John will probably smile when I say this, but that isn't going to be challenge free in terms of both practical issues, but also the kind of mindset of the staff and the teams and the users who have got to be brought on that journey. It's very easy, I think, as a user to go, I'm very happy with my little system that works very well for me here. I don't really want to be part of a bigger system. So I think we have a mindset journey as well as a practical journey to go on. And I think that in the current times is quite challenging, but is going to be a big part of the transformation that we have to do is people as well as systems. But overall, I think it's a very comprehensive plan. And I think it would be good to review it annually. And as John says, see that 2-year forward view, because I think that's really, really important.
Splendid. Thank you. Ian.
I'd absolutely endorse the points you've just made around actually, in sometimes the technology is the easiest bit to do. And actually it's the people, and particularly it's people when you're doing it across organisations. So I guess it's what I saw in here was great from a DDAP perspective, but almost more emphasis on training and piloting and all of those things. I'd encourage to almost bring out because that I think that will make it stronger. I think with my briefly slipping my chair of the ARC on, I'd sort of look at the comment that you've got on cybersecurity on page 77 around massive concerns about patching in a timely way. And I guess the boards have to be strategic, but that looks like a tactical real issue. And I'm not certain that if in the way that it's written, I'm seeing that necessary in our overall risk for the Foundation Trust. So could you just give me some assurance around that? Because to me, patching is the absolute number one that has to happen if nothing else has to happen.
Yeah, I can give some assurance around that. So obviously we have the NHS firewall, and we also then have Darktrace and micro transfer endpoint protection. So we're as good as we can be. And if we look at what happened last month with Logi4, we were on it within 2 hours. We were monitoring our that we were being scanned by 25 people, and nothing got in. And we've now got a list of all of our vendors about the timeline in which they're going to sort out their vulnerabilities, because the vulnerabilities is with the products that we've purchased, not with the way in which we've deployed them. So I can give you the assurance in sort of real terms, Ian, that our cyber is as strong as a foundation trust can be. That does not mean I can guarantee this board we will not be cyber attacked, which is the reason why it's worded so strongly.
I think despite your assurance, it would be sensible to anticipate an invitation to the Audit and Risk Committee, John, but I'm sure you'd welcome that as part of a road the strategy.
And I think if you to guarantee, John, that we weren't going to be cyber attacked, I would be almost more concerned.
Thank you.
Thank you both. Paul, please.
Thank you, John. In the SWOT analysis, there's a phrase which says untested contingency planning. What are the implications if those contingency plans don't work? And what are they for? And what are the mitigations that are now being put in place to test those contingency plans to make sure that the organisation can still work based on the contingencies that have been put in place?
So we're going through, thank you, we're going through a process of testing our contingency plans. And indeed, with all of the ward moves that we've had recently, we've had to deploy a large number of them. This is particularly around the increasing use of digital in the minute by minute, hour by hour care we deliver. So our contingency plans around, for instance, our EPMA, our electronic prescribing solution, or ensuring that the right patient is seen in the right place at the right time on the patient administration system, have all been put in to play. And there are some that we haven't tested, and there always will be, as I'm sure we can understand, particularly worst case scenarios such as losing all power for a period of time, losing the complete internet totally, particularly as we move to more cloud-based. So there's always going to be a degree. The weakness is less than what it has been in the last 3 or 4 years. We will always have to be open that there's a degree of contingency planning, for disaster planning I'm talking now, that we can't necessarily test, although we have a plan for. So there's limited assurance there, I'll be honest, yeah.
Helen, can I just come back? John, are there any major systems, and I'm going to have to use your professional judgment on that have been put in which haven't been contingency planned, which would have a significant effect on patient care or the organisation going forward? That's a system rather than something like a total blackout, etc. And if so, what are the mitigations and what are you doing to ensure that there is some assurance behind that?
So there's contingency plans behind every one of the clinically deployed digital systems that we've got. And as I say, those have been tested and in fact are utilised probably once every 8 weeks when we're doing the patching work on those systems. We deliberately take them down at 3 o'clock in the morning on the second Tuesday of the month and then bring them back up in time for business as usual at 7:30 in the morning. And that is something that we've been doing with increasing regularity. We now have a workflow for that, whereas before we hadn't, and we had to come begging and borrowing really to the operational aspect of the organisation, saying, do you mind if I turn this off at 3 o'clock in the morning? It's now become business as usual. I think it's also relevant to say at this moment in time that the biggest weak point that we did have was actually in hardcore infrastructure with the way in which our servers were mirrored. And we've been able to change the switching of those servers where we're never reliant on one server. So, and that's not including the cloud backup, that's there as well. So we have significant contingencies for what is foreseeable.
Thank you, John. Last word, Sue.
Thanks, Helen. I'm conscious of time. It might be better that I just go offline to John about, because I've got about half a dozen things I wanted to ask. But just very quickly, I'll ask one if I may. And well done. The paper's very digestible and has moved forward massively. So thank you. You, on one of the pages, it talks about the bids in December 21 into the fund. Have we got all of those, or are they still in bid format? And that's the first question.
So the finite detail of some of those bids is embargoed, and I'd be more than happy to discuss those in private board very briefly. It would take me a couple of minutes, but it's a very successful looking landscape.
1.5 million down for ESR. Will that do it, or is that just to get started and then there's another funding thing that we need to follow up?
Again, so the EPR, so that will fund part of the journey. However, there's an ongoing dialogue with NHS Digital, which is being worked up by way of the 250k seed funds to give a full Green Book 5-point business case. And there is a challenge to the organisation whether to follow NHS Digital's funding as an Aspirant Plus organisation or to consider other financial pathways. At this moment in time, there's a lot of uncertainty about how we as a trust would benefit from either direction, which is why I've not come to board to get to have that discussion yet. That I think will be my next major discussion point with colleagues out of board and in board about strategically how we would want to invest a 10-year investment into an EPR, keeping the ramifications of what that would mean to the system in the forefront of our minds.
And the final question, based on a lot of what we've talked about today, is there's a lot of stuff, isn't there, coming, lots of priorities, lots of things we have to do. Whilst I am personally convinced that EPR is a thing that we need to do, I don't think what is clear in the paper is how we've got to that conclusion. So we've kind of gone, there's all this stuff, we've got this landscape, we've got all these challenges, here's the plan. And then it seems to go, and EPR is a really great idea, which, I mean, I know it is, but I think it might be helpful to understand why we are choosing to spend, because it will be a lot of time and effort and disruption and cost on doing that, and why that will give us the biggest bang for our buck. As I say, it's not that I need to be convinced, having been on the ward with you the other day talking about exactly that, John, but still, I think it would be diligent to be clear about that.
Absolutely. So this was part of the greater plan in the previous strategy, was to onboard the organisation and those that work in it by showing the impact of digitalisation on the minute by minute, hour by hour, week by week work that people do, which was part of the HSLI funded digitally enabled healthcare. So that's EOBS, Connect, and then looking at, although we have not yet to finally decide for reasons I'm more than happy to discuss, like offline, the new whiteboard solution. Being relatively late to the party is something I really like. I don't like to buy brand new tech all the time. I think that it's liable to waste public money and to cause the staff to be antagonistic towards any form of change, whether it be digital or not. The way in which we're looking now into pushing the EPR through the front door is really timely, because the EPR and ED is sunset and it's approaching end of life. This should have, I'll be honest, this should have happened 18 months ago, but for obvious reasons hasn't. So it's the obvious extension in our journey. We already have the notes repository for what's in the right hand side of the notes, which is all of the letters and such like, and results. So it's the obvious next thing to do. There are other obviously huge benefits of EPRs in terms of visibility and system working as well. So the reason why it's the EPR version of the strategy is that's the obvious direction to travel in, because we've not done what other organisations have done, which has gone EPR first into an antagonistic workforce, not seeing what the benefits of digitalisation are. So there's been quite a protracted nudge theory process for the staff to be ready for EPR.
Well, thank you, John. I think there's a unanimous view that it's an excellent strategy. We're happy and looking forward to reviewing it annually. We think your sense of having a horizon of 2 or more years is very sensible. And perhaps before putting the final touches to it prior to communication, you might want to reflect on Sue's counsel about strengthening the case for EPR, not least of all in recognition of the point Ian and others have made about us having folk ready as much as us having any process change ready that's going to be the difference between a good or an outstanding execution of the strategy. So well done. Thank you.
Thank you.
We're now on to the last two items of the meeting, and the first of the two is a rather big item because for those who are new around the table, including our observers today, it looks like a fairly pedestrian item, the Board Assurance Framework, but the Board Assurance Framework is actually where we tie together the work that takes place in our committees with any escalations or assurances that need to come to board. And of course, in those committees, they're looking at the IPR, which is the Integrated Performance Report, the Risk Register, and they're considering the Board Assurance Framework and any changes that might need to be made to that. So I know Angie and executive colleagues have been doing quite a bit of work on the Board Assurance Framework itself. So I'm going to start with Angie, and then we've had meetings of the Quality Committee and the People Committee since we've last met. So we'll have an update from Jane and Jeremy. So in that order, please, Angie.
Thanks, Helen. Just 3 points from me. As you say, colleagues have been working on the framework, and a particular thanks to Liz, who's kept us all in order and made sure that we've got that objective view and consistency and detail in the BAF. So hopefully you can see that work in progress in front of you. We had a bit of a discussion and debate about where restoration and recovery sits, and that was pre the last few weeks. And clearly a big strategic issue for our patients and for us as a board to consider. For now, we've put it in both 1 and 5 for obvious reasons, I hope, but that's still to go through Quality Committee and F&P, so maybe some discussion back at board next time, or happy to today if you want to do that. And then final point is that we're having a deep dive at ARC next week on BAF 3. And in light of some of the conversation today, really looking forward to that one because it's going to challenge us, I think, in terms of how we frame that one. So they were the 3 points from me. Thank you, Helen.
That's really helpful and teases up nicely. Jane.
Thank you, Helen. So just 2 points from me. You've got the summary from the QAC meeting from November. Just want to bring to the board's attention 2 items that we have with limited assurance. The first one was emergency preparedness, resilience and response. Really that was, we were only partially compliant with core standards, and it's really about us moving from a centralised model to kind of a more disparate model across the trust where ownerships is really much more widely spread. So we're having an update on that in February at the next meeting. And then the second matter with limited assurance was maternity. Board are aware that we've got ongoing discussions about the governance structures and about the assurances that we receive through those structures. And we've had a review done by 360 Assurance, and we're also having some further critical friend visits on that in the near future. And again, I don't think it's anything new. I think board are fully aware of the issues, but we're going to have a more detailed discussion again at February board. So in terms of any recommendations around the BAF, we had a good discussion about whether these 2 items were new to us, so to speak, in terms of limited assurance, and felt that the position had not deteriorated, and in fact we were fully informed. And so our recommendation to board is that we make no changes to the BAF scoring. Oh, one other thing, Helen, I note that there was a comment from Krishna around Ockenden and saving babies' lives on an earlier item, and I think that's a good idea that we do have a bit more of an in-depth discussion at board about maternity. I think it's on everybody's minds, and clearly it's still very big in the sort of national picture. And I think we would all appreciate being able to air some of those matters. And I know that we're going to have a little further update in private board about some of the operational issues.
Very, very helpful, and I'm sure John will have taken an action around that for a future agenda item. So yeah, I'm sure we'll all be very supportive of that. Thank you.
Sorry, Helen, can I just ask Krishna if there was anything else that she wanted to update on maternity?
It looks like there is.
Yes, thank you. So just for board's perspective, we've invited sort of our local maternity and neonatal colleagues from the CCG and NHSEI in to support us with the Critical Friend visit, and that is really to support us going forward with our risk and governance processes. So from an assurance point of view, we've still got good outcomes for our mothers and babies, and we've got really good feedback from our mothers as well. So it's more from the organisation and getting us on track to make sure that we deliver on the Ockenden outputs and the improvements and the learning. That's really what we're hoping from that supportive visit. So we've just for boards to be aware of, we've actually pushed back the visit because it was going to be next week, and in view of sort of the current pressures. NHSE are more than happy. The visit is now going to go ahead on the 1st and 2nd of March, which will be just in time. So again, just to highlight to the board, we have appointed a new head of midwifery, which we are anticipating that Amanda Mansfield will be starting either at the end of February or the beginning of March. So this is perfect timing for her to get an understanding of what some of those sort of top sort of 10 things that we need to sort of address. I think it'd be really, really helpful and supportive for us to move forward to progress sort of that improvement journey within maternity.
Very helpful, thank you for that, and of which I'm sure more later. Thank you, Krishna. Jeremy.
Thank you. The only thing I would add to the written report, which is in front of you, is that I have now drafted a summary report on the discussion we had about the internal audit report on consultant job planning. So I've been able to pass it on to Ian for consideration at ARC next week. But otherwise, please take the report as read.
Thank you very much. Does anybody have any questions or comments on the back of what you've heard from Angie or Jane or Krishna or Jeremy, or indeed the written reports? Content to note. Thank you very much. In which case, we're going to move to the last item of the day, which is the patient and staff experience report. And we've got another duet, Krishna and Zoe. And again, the paper is very fulsome. So if you'd be kind enough to tell us anything new or give us a steer in terms of the conversation you'd like to have now, that'd be helpful.
Thank you, Helen. I'm going to kick off and then hand over to Krishna. So as you said, the paper is quite thorough in terms of its detail around our exec sponsor activities in particular. I'd just sort of summarise those for board in terms of the value I think that we're seeing from the time that we spend. So time spent informally in departments talking with people, the listening sessions that we have with Abby, which she talked about earlier in her report, both from a listening and people being heard perspective, as well as the actions coming out of those. I think that is having an impact for people in teams, and also in December as execs we spent quite a lot of time around the organisation, including our off-site bases delivering chocolates, which was really quite a small token of thanks and appreciation, small act of kindness, and was really appreciated by people. So that they were done very well. And I will hand over to Krishna.
Thank you, Zoe. Just to update on the real-time patient feedback from last board, we've actually purchased it. We've got it up and running, but it's being sort of run currently by the quality governance team to make sure that we're being responsive whilst we train up. So we're going live with surgery. So we're currently training key members of the leadership team and the ward teams to be able to respond to that feedback, and then whatever learning we get from that, we'll be able to cascade, and we're trying to do that at pace throughout. But be assured, we've purchased it, it's up and running, and we'll see what it will bring back to feedback to future boards on how it's going.
Well, Krishna, if you told me that on Christmas Eve as opposed to in the papers for this meeting, I think it would have been my best Christmas present. I couldn't be more excited, and I'd like to ask that we have when we have the staff story or the patient story, that we use this new tool we've got to either be the basis of the staff or the patient story at a future meeting, because that would also have the effect of probably giving us a little demo as a board, which will be a great thing to have if you be willing.
Yeah, that's fine, Helen.
Very good. Anybody want to come in on this item? No. It will be time to refresh the teams and the exec sponsor leads in the not too distant future once the staff survey results are published, because that's normally our trigger for doing that. And I know on the back of some discussion at the Council of Governors that Zoe and colleagues are giving some consideration to how that might also cast some light on where it is we'd most appreciate governor support in terms of helping teams that are particularly challenged in these difficult times. So more of that too on a subsequent discussion of these teams and priority areas. So thank you very much for that, and well done. And it's very easy, isn't it, to just note the report, but as Zoe said, there's been a huge amount of shoe leather spent by executive colleagues, and your visibility, particularly as Zoe said in the run up to Christmas, I know for a fact was hugely appreciated, and I'm sure you'll continue to do lots of them in the new year. So we really do appreciate you prioritising that style and tone of leadership, because we think it's completely in tune and a great manifestation of what it is we espouse as a board in terms of culture and ways of working. So a big thank you to executive colleagues, one and all, for that. The other items on the agenda are consent items, of which I've had no prior notification of anybody wishing to raise any of them, so we will leave them as consent. And the other items are for information. That brings us to AOB. Are there any items of AOB? In the absence of any items of AOB, it brings us to the review of the meeting. For those who haven't been to this meeting before, I probably should have told you earlier, but we tend to go to people in what we metaphorically describe as the cheap seats, because when we met in person, the seats were all lined up against the wall and they were slightly more close together than ours. Not a lot, I hasten to add. So for those who have come to visit us today, we will be particularly pleased to hear your reflections on the meeting, how you found it, and particularly if you're more or less assured about patients and how they are looked after at Chesterfield Hospital by virtue of what it is you've heard us do or failed to do in today's meeting. So not wishing to put anyone on the spot, but feel free to say as much or as little as you like. Can I go to you, Carol, in the first instance? You're on mute, Carol.
Oh, that's it. Can you hear me now?
We can.
Good. No, just a few thoughts. Obviously, there's been a lot discussed, and I'm very new to the job, not to the trust, but to the post of governor. I think it was a helpful introduction, actually, giving me a flavour, a context. It put names to faces, which always helps when you are communicating with people. I do feel ill-prepared, really, due to technical difficulties with my laptop. I was trying to read the 98-page paper on my mobile phone, and so apologies if I'm not as well prepared as I would have liked to have been. I think I must admit I gave up very early on, thinking it wasn't sinking in. But no, I appreciate it. I'm looking forward to the challenge. I'm looking forward to whatever it is I'm going to be doing. And this is who I am. I retired a month ago from the hospital at the end of November. So it's quite nice to see some familiar places, just in a different faces, just in a different context, really. So that's my feedback. I've enjoyed the meeting. Thank you very much.
And we're always grateful to governors for giving up their time so generously and freely as they do. But when somebody comes back to the trust as quickly as that after their retirement, they know that we must be doing something right. So thank you for your generosity, Carol, and we look forward to working with you. Nick.
Yes. Hi, good afternoon. That was quite an eye-opener, really.
I feel as if I'm trying to learn a new language. My own experience is actually as a sales and marketing director in the private sector to do with manufacturing. And it's quite noticeable the difference between board meetings of the trust and board meetings of a PLC. They're a lot less combative, should I say. There is a lot more cooperation between board members with the trust, and there's a lot less one-upmanship that seems to go on. I've relied on the NHS in order to have a career, actually. Amongst a lot of other things, I've suffered from Crohn's disease for 46 years. And when I was first diagnosed, I was told to give up work and avoid pressure, which I haven't done. So I'm very grateful to what the trust has done for me and for my family over the years. What heartened me during that meeting was the integrated data digital systems that's going on. I can remember it's not very long ago that if I had a blood test done at the Royal Hospital on the say-so of a consultant, my own GP didn't get the results or couldn't view the results. And the same for when you go to the Red Hub at the DCA. So the fact that we're integrating systems, I think, is very heartening. And what I would like to see is that when I go to the hospital for a blood test, rather than just going home and wondering what it was all about, is a system whereby I think Sheffield have actually got it, called Patient View, where I as a patient can actually view the results of any blood tests, any reports, any letters that are done. I don't know whether that's part of the agenda of the board. Maybe somebody could enlighten me on that.
Thank you, Nick. Let's invite a very brief comment from John on that, if we may, but I'm sure in Council of Governor meetings, Nick, there'll be plenty of opportunity for you to progress what seems like a very sensible and ambitious approach. John.
Yeah, Nick, thanks very much. I'm more than happy to come to the next Council of Governors and to show the NetCall Patient Hub that we're developing that now texts you when you've got your appointments and such like. And the functionality to be able to give you your results is in a pipeline. I can't tell you exactly when that's going to happen. I will get the information to you. In addition to that, we are going to deploy the shared care record across Derbyshire. I can't give you an exact date. It will be within the next couple of months. This will allow us in Chesterfield to see all of Derby's letters, discharges, results, etc. as well as obviously GPs and paramedics being able to see it. So that shared care record is just being tweaked at the moment before it's launched. It'll be launched small scale and will grow, and it's a 10-year project. But for the results and the patient hub, I'll get more detail to governors as soon as it's reasonable. No problem. Thank you.
Thank you very much. Thank you.
Thank you. And last word in terms of reflections on today's meeting. Can we come to you, Ruth, please, Ruth Ludford?
Hi. Yeah, once again, a very good insight into everything that is going on and how the hospital has and is continuing to cope. I think the two interesting things for me were Abby's freedom to speak, and very pleased to hear that there is going to be some plans put in to support the staff in RPC, especially at the moment the sort of negative reports that are going on about primary care. I think that's very important that the staff are going to be able to speak up with Abby. And the other interesting thing was the education. That was very interesting to hear a different part of what goes on in the hospital and the education, and hopefully it does lead to more, what's the word I want now? I think the disability, or the not just necessarily depending on doctors and nurses, but the other occupations that are available within health and social care. So that was really interesting, that beginning.
Thank you very much, Ruth. And thank you again to all of you who've joined us this morning. We really do appreciate it. There's going to be a closed session of the board after this meeting. We have a short closed session for any items that are either sensitive or, for example, commercially confidential. We keep items in that meeting to a minimum because we think the transparency of conducting business in public forum is important, but it's not always possible. So we'll move into that next. So consequently, I'd like to take a straw poll from my board colleagues. Would you like to have 15 minutes between 12:15 and 12:30 to make yourselves a cup of tea before we come back to do the private session? Or would you prefer to carry on and then we can have a break after the private session and before we go into the Remco? All speak or forever hold your peace.
I'm up for carrying on.
Carry on.
Yeah, carry on.
Me too. Yeah, carry on.
Carry on. Very good. Let's carry on and then we'll have a break after the private session before we go into committees. Very good. So thank you all again. And for those of you who are not dialed into the next meeting, we look forward to seeing you soon. And particularly warm welcome and big thanks to new governors and old governors for coming today. Take care.
Thanks all. Bye.
Bye-bye.